Hey everyone, I'm James. I'm the academic coordinator for MUPPITS this year. So this is the genitourinary lecture. This is a pretty short topic. So we'll mainly cover the big conditions, which will be UTI, vesico-ureteric reflux, and nephrotic syndrome. But we will touch on most of the other stuff that is important for your exams. So starting off with UTIs, so in terms of the causes of UTIs, it is quite similar to adults. So E. coli causes the vast majority of cases, of around 80 to 90% of cases. But the other bugs to consider would be some gram negs like Klebsiella and Pseudomonas. A couple of gram positives, mainly would be Enterococci and coag neg staph. And then in very specific cases where kids are immunocompromised, you might consider some fungal and mycobacterium causes, but these are very rare. Some of the main risk factors that will predispose kids to developing UTIs, obviously any anatomical anomalies of the urinary tract can predispose to developing UTIs. The female sex, essentially after infancy until death, will correlate with an increased risk of UTIs. Although as infants, it's very specific in that males are actually at an increased risk during that period. Um, any uncircumcised male is at an increased risk of UTIs as in comparison to circumcised males. Any sort of bowel or bladder dysfunction, which we'll talk about in a little bit, vesico-ureteric reflux, and then other things would be type 1 diabetes and direct trauma to the area. In terms of how it presents, this is very dependent on the age of the child. So with older children, in particular teenagers and older, they'll present very similar to adults. So essentially the same symptoms of fever, dysuria, increased urinary frequency, and suprapubic pain. They might have some urinary incontinence, but that's largely dependent on the age. You wouldn't really be expecting a teenager to lose continence. In infants, the main feature that would tip you off to the possibility of UTI is reversal of toilet training. And so in kids that have gained continence and then suddenly lose continence with systemic infective features, that's a big hint that maybe there's a UTI going on. But the other symptoms are mainly non-specific, so fever, diarrhea, vomiting, and abdo pain. In neonates, it's even more non-specific. So it can just present with a fever without any focal symptoms. And your main non-specific features would be things like poor feeding, irritability, jaundice, failure to thrive, or weight loss. Malodorous urine would probably be your biggest tip-off. But essentially, the way that most of these are diagnosed is that there'll be a fever in a neonate, and they'll do a urine MCS as part of a general sort of checkup. Moving on to investigations. So the general principles of investigating UTIs is that all children that might have a suspected UTI should have a urine sample collected. And we'll talk about the different types of urine samples in a second. And this urine sample should be ideally collected prior to starting antibiotics to increase the likelihood of growing a bug on the urine MCS. But this, obviously, if the kid is very unwell or if you're suspecting something like urosepsis, then you should just start empirical antibiotics before waiting for a urine sample because they can take some time to collect. So the different types of urine collection essentially depend on the age of the kid. So if the child is able to void on request and able to follow commands, then you can do a midstream urine. Whereas if the kid is pre-continent and then not seriously unwell, then you can go for a clean catch. So these have relatively high contamination rates of around 10 to 15%. So as a result, the gold standard for diagnosis is actually a suprapubic aspirate because that has a contamination rate of around 1%, which is obviously very low. But it can be a bit more invasive and painful for the child. So this tends to be reserved for very specific cases. An in-out catheter is generally used if a clean catch or an SBA has failed and it has a decent rate of contamination. And then bad urine is really not recommended. So there's up to a 50% contamination rate. So that test really isn't reliable. So that's on the left is a suprapubic aspirate. So essentially you just go slightly superior to the pubic bone and you aspirate urine from the bladder. Whereas a clean catch is on the right, you essentially clean the area, sanitize, and wait for the baby to pass urine. But again, that has quite a high contamination rate, obviously. And it can take some time and is quite dependent on parents being compliant with it as well. So your main investigations once you get the urine would be a urine dipstick. This is a screening test, so we can't diagnose a UTI based on a dipstick. But the things that would suggest a UTI is positive lukes and nitrites. Uh, and just to note that there's a higher rate of false negatives in neonates and infants than there are in other age groups when doing a dipstick. Urine MCS, essentially, if there's a growth of any organism at more than 10 to 8 per liter, that would suggest an infection regardless of which collection method it is. So even if it's one of the the collection methods with a high contamination rate, that is sufficient to tell you that there probably is a UTI. Whereas if you're doing an SBA, then any growth from that would suggest infection. And again, that's because of the very low contamination rate. The other investigations are mainly dependent on the scenario. So if a kid is seriously unwell or if they're not responding to treatment after 48 hours, then they need UECs and they need a renal ultrasound immediately. There are some indications for renal ultrasounds at later dates, but this is a main indication for a renal ultrasound to aid diagnosis. And then other things would be a blood culture and a lumbar puncture, which are mainly only indicated if the child is very unwell and they're less than 4 weeks of age. In terms of the management for UTIs, I think it would be good to know when to consult local peds if you're in the community, or when to just call the pediatric team if you're in the hospital. So if the child is less than 6 months of age presenting with the UTI, if they have any known renal tract anatomical anomalies, if they're not responding to your initial therapy, so if you have a persistent UTI despite antibiotics, or if the child is just seriously unwell. So if they're septic or you're just worried about the kid, then that is enough to consult with peds. The empirical therapy, if you want to go orally, the main treatment would be Keflex, whereas for IV, it would mainly be Gent and Benpen. And this is empirical, so while you're waiting for cultures to return, cultures sensitivities to return. IV antibiotics are only indicated if the child is seriously unwell or if there's an infant that's less than 3 months of age presenting to the hospital. And mainly the main goal here is to be able to switch from IV to oral as soon as possible. In terms of the follow-up, not all children need follow-up. So the ones that do, if they're seriously unwell, as we've mentioned, if they have any renal impairment as a result, or if they're a boy that's less than 3 months old, then they need a renal ultrasound before they're discharged from hospital. If they have recurrent UTI, so they've had a few similar presentations, then they need a non-urgent renal ultrasound, which can be done as an outpatient. And if there's a recurrent UTI or if there's a known urinary tract anomaly, then they need specialist urology follow-up. Cool. So that's UTIs. Moving on to vesico-ureteric reflux. So this is defined as retrograde passage of urine from the bladder back up into the upper urinary tract. And essentially, the main two subtypes are primary and secondary. So primary is by far the more common type of VUR. And essentially, the pathophysiology behind it is that there's inadequate closure of the VUJ. So the normal physiology is that during when you're voiding, your bladder wall contracts, and when it contracts, it essentially constricts the intravesical ureter, so the part of the ureter that's within the bladder wall, and it means that urine doesn't flow back up into the upper urinary tract. So that's a normal physiology. In primary VUR, you have a congenitally short intravesical ureter. So when the bladder wall contracts, it doesn't shut off the VUJ, and you get reflux back up into the upper urinary tract. So the main thing to take away from here is that primary VUR will often resolve with age, so it's not common that this will be severe and will need management. Secondary VUR is mainly caused by high voiding pressures in the bladder, which in turn causes failure of the VUJ to close. So this is often associated with more anatomical things like posterior urethral valves or some sort of functional bladder obstruction. So something like constipation or so on. This is a grading for VUR. I don't think it's particularly important to know, but it is essentially the grade will dictate what the management is. So grades 1 and 2 are quite non-severe, whereas grades 3 to 5, you're getting more and more severe, and the risk of complications is increasing. So the diagnosis of VUR, essentially the main way that this is diagnosed will be following a UTI, and you get an abnormal renal tract ultrasound, and as a result, the child will go on to have a Vesico-ureteric. So that's pretty much only indicated if the renal tract ultrasound is abnormal. So this is the most accurate diagnostic test by far. So this is what most kids will get to diagnose VUR. The alternative imaging, RNC, CE, VUS, and DMSA. I don't think you have to know that, but just to give you an idea that there are alternatives if for whatever reason the VCUJ is contraindicated. So the complications of VUR, the main one would be recurrent UTIs. So as a result, you can get quite severe infections like pyelo. You can also get a loss of renal parenchyma, and as a result, you get progressive CKD. In turn, you can also get hypertension, which obviously in a child isn't obviously a good thing. And in specific cases where there's prenatal VUR, so that's when VUR can be picked up on prenatal scans, then the baby can get congenital renal hypodysplasia when they're born. So the main goal of management is to prevent the complications that we talked about. So for grades 1 and 2, the mainstay here is normally surveillance. But this can only be done for toilet trained and verbal children because they have to be able to verbalize when they need to void. So for kids that aren't toilet trained, aren't verbal, and then also if they have any recurrent UTIs or they have known renal scarring, then they need antibiotic prophylaxis. So surveillance isn't enough for those kids. They need antibiotic prophylaxis to prevent UTIs and pyelo. And just routinely, surgical correction isn't offered for grades 1 and 2. So it would be a very special circumstance where surgical correction is done for grades 1 and 2 VUR. In comparison, for grades 3 to 5, all these kids will have antibiotic prophylaxis just because the risk of infection is so high as you get more severe. Other goals of treatment would be to try and improve bladder and bowel dysfunction. So in particular for secondary VUR, then trying to sort of improve the comorbidities can lead to improvement of the VUR symptoms themselves. And surgical correction can be indicated here. So it's indicated if there's grade 4 or 5 VUR that exists beyond 2 to 3 years. If there's any failure of medical therapy or if there's significant side effects from antibiotics for whatever reason, and the child can't have antibiotic prophylaxis. So in all those cases, you would go on to surgically correct it. Cool, so that's VUR. Moving on to nephrotic syndrome. So nephrotic syndrome obviously presents with the classic triad of edema, proteinuria, and hypoalbuminemia. So the most common in kids by far is minimal change disease. So in around 90% of cases in the peds population, the diagnosis will be minimal change disease. And the classic presentation is in a young boy. The clinical features, the main buzzwordy ones will be peripheral and orbital edema. So if you're seeing bilateral orbital edema, in the absence of something like a cellulitis, then your biggest differential would probably be nephrotic syndrome, particularly if there's whole body edema as well. The other symptoms can be a bit non-specific, but they're mainly related to a loss of intravascular fluid. So having things like dizziness and abdo cramps. If it's quite severe, you can get cold peripheries, modeling, prolonged cap refill time, and super severe, which would normally require hospital admission, things like tachycardia, reduced urine output, and hypotension. So that would indicate that that nephrotic syndrome is quite severe and it's causing uh, quite severe complications intravascularly. The other things would be thrombosis and infection. So kids with nephrotic syndrome at an increased risk of thrombosis due to venous stasis and also to infection as well. So the main types, as we talked about, minimal change is definitely the most common, particularly in very young kids. So it's an idiopathic disease, so they're not quite sure what causes it, but it tends not to progress to CKD, which is probably the big thing to take away, is that it's usually benign, particularly with treatment. It occurs much more commonly in males and females, and it peaks around 2 to 5 years of age. On biopsy, so going back to path, there'll be effacement of foot processes. So that's very buzzwordy for minimal change. The other main two types that you would see would be focal segmental GN. Again, this is largely idiopathic. It has a poor response to corticosteroids. So the main way that this is diagnosed is if nephrotic syndrome is assumed to be minimal change, and they're started on some sort of steroids, but they're not improving. That's when you'd start to consider FSGN. But this isn't particularly common, especially in comparison to minimal change. And the note here is that this can progress to CKD. So this tends to be a bit more damaging than minimal change. And without treatment, it can go on to cause renal damage. The other main one to consider would be membranous, but this is a lot more common in adults than it is in kids, although it can occur. So this is an autoimmune process that's associated with ANA, and again, it tends to respond pretty well to steroid treatment. The investigation, so essentially to diagnose nephrotic syndrome, you need proteinuria and you need hypoalbuminemia. So the proteinuria, you can do a urine PCR, a protein creatinine ratio, which would be greater than 0.2, and essentially an albumin level of less than 25 would indicate hyperalbuminemia. So that's your main diagnostic criteria. The investigations to do, you can do a dipstick, which would show very high proteinuria, so 3 to 4 plus probably. Urine microscopy would probably show some hematuria as well, just coexisting. You'd have to do, as we just talked about, a urine spot protein creatinine ratio, and then just your basic bloods, FBEs, UECs, and LFTs, including albumin. The management of nephrotic syndrome, if it's a first presentation, the child has to be admitted to hospital. If it's recurrent and you know that it's not serious, then they don't necessarily have to be admitted, although most children with nephrotic syndrome would be admitted to hospital. The mainstays of treatment, there's a few things that you want to manage. So the first one is the edema management. So putting the child on a strict fluid and salt restriction. Doing daily weights and daily dipsticks to monitor disease progression is very important as well. And if there's quite severe edema and they're very intravascularly volume depleted, then you'd consider things like IV albumin and furosemide. So that would be reserved for quite severe cases where there's some sort of shock involved. Steroids are your main treatment. So Pred is normally the go-to steroid, and this will likely induce remission, and it'll essentially induce remission. And if it's slowly weaned, then it can help to prevent relapse. So yeah, like anytime you use Pred, it has to be very slowly weaned off. Just to note that if they're given Pred or some sort of steroid to treat nephrotic syndrome, that they can't have live vaccines during this period. So just delaying live vaccines until the treatment course is over. Antibiotic prophylaxis isn't recommended unless there's a particularly high risk of pneumococcal infection. So that would mainly be for immunocompromised kids. Post-infectious GN, this will normally present with hematuria, which will classically occur 2 weeks, roughly following a UTI or a skin infection. And that will be contrasted to IgA nephropathy, which we'll talk about in a second. The complications are an AKI and hypertension would be the main two complications to worry about, although this can be quite severe. The investigations to diagnose post-infectious GN are an anti-streptolysin O titer, so that would be high, a high anti-strep DNase B, and then a low complement C3. So I don't think you have to know that, but it could be a bit buzzwordy as well. I didn't mention it before, but this is mainly caused by some sort of strep infection. So it's the same thing as post-strep GN. The management, this should spontaneously resolve within 2 weeks, even without treatment, although corticosteroids would be the mainstay of treatment if you were to decide to treat it. And then the other supportive sort of stuff would be, again, a fluid and salt restriction. And so IgA nephropathy, so contrasting that to post-strep, this classically presents around 2 days following an UTI, so very a much more acute presentation here with episodic frank hematuria. This can cause progressive CKD, so it is quite severe and it does normally require treatment. HSP is something that does present with IgA nephropathy, but it would also present with classically a non-blanching petechial rash, some more systemic symptoms like joint pain and swelling and abdo pain. Cool. Alport syndrome, this is very buzzwordy again. So this is an X-linked dominant syndrome. And essentially the pathophys is that there is a deficiency in type 4 collagen, which is mainly found in the basement membrane. And it can, as a result, having a deficiency can cause leakage into the urine. So this will present with classically sensory neural hearing loss and eyesight issues, as well as just symptoms of kidney disease, so hematuria, proteinuria, and kidney failure. So if you see a triad of kidney disease with hearing loss and some sort of eye abnormality, then that is very much buzzwordy for Alport syndrome. Well, moving on to enuresis, or essentially urinary incontinence. This has 2 main classifications, so you can either be primary or secondary. Primary would be when the child has never achieved continence. So this would be mainly older children that are, not older children, but children that are beyond an age where you would expect them to have continence, to be continent of urine, but they're not quite there yet. Whereas secondary is when the child has been dry for more than 6 months, and then they then go on to develop incontinence. So as we mentioned before, essentially there's a reversal in their continence. And that would lead you to suspect that maybe there's some underlying sort of pathology rather than it being behavioral. The milestones to normally meet toilet train. So children are normally toilet trained by the age of 3 years old. By 4 years, they shouldn't be bedwetting anymore. And by 5 years, they should essentially be fully continent. So if they're not meeting any of those milestones, then you would have to start considering maybe there's something going on here. The causes can be split up between functional, medical, and surgical. So the functional causes can include psychological things like anxiety, depression, things like ADD as well can cause it, as well as behavioral issues. So in particular, any problems with bullying at school can lead to enuresis, and then sort of more basic things, but something like excessive fluid intake or not urinating before going to bed can cause enuresis or nocturnal enuresis. Medical causes, diabetes and constipation would really be the 2 main ones here. So obviously diabetes would be more likely to present with more systemic symptoms, so polyuria, polydipsia, as well as just your other sort of general symptoms of diabetes. And constipation, so that would cause some sort of outflow obstruction and lead to a type of overflow incontinence, essentially. Recurrent UTIs can damage some of the anatomy as well and lead to issues with continence. Surgical causes would be mainly anatomical things, so any anatomical bladder abnormality, but also any spinal cord abnormality. like something like an abscess or a lesion somewhere in the spinal cord. In terms of the management of enuresis, the ideal ideal sort of management would be to identify and treat the underlying cause, if that's possible, although that obviously isn't always possible. Trying to encourage behavioral changes, so things like encouraging regular toileting and trying to limit fluid intake before bed. And on top of that, encouraging toileting right before bed as well can help to reduce symptoms of nocturnal enuresis. Keeping a bladder diary is something that's recommended. So this is just like a short little diary that will note the fluid intake, the times that that's happened, and then the frequency and the volume of urine. An enuresis alarm is a really good thing, but it's essentially is dependent on the child being able to follow commands. So this will normally be used for kids that are above 5 or 6 years old. And then your last line sort of treatment, you'd start to consider synthetic pharmacological drugs. So the main one would be desmopressin, which is essentially synthetic ADH. So this is actually very useful for children that have nocturnal polyuria with normal daytime voiding. So pretty much all the issues are at night. And it can also be used if there's sort of a prompt need to correct the enuresis in the short term. So it can be used for if the kid's going to camp or something in a couple of weeks. It can be used to sort of manage symptoms very short term. Cool. So that's enuresis. Moving on to hypospadias. This is, again, quite a short topic. It's not too important. But essentially, a hypospadia is a congenital anomaly with abnormal ventral displacement of the urethral opening. So the urethra is normally located more ventrally than it should be. And depending on where it is, it can have different severity of symptoms. So it is relatively common. It affects around 1 in 150 boys, so a bit less than 1%. And the main clinical features, other than a abnormally located urethra, would be a ventral curvature of the penis and a hooded foreskin. For very severe hypospadias, this will normally be where the urethral meatus is located somewhere in the scrotum or the perineum. So it can be very far away. So you can see on the right, that's a scrotal urethral meatus. It can even be even further back than that. The management, essentially the only way to manage this is surgical correction. This isn't indicated for all kids, obviously, so it's only indicated for quite severe cases or if there's some sort of family preference. So it is an elective procedure. It doesn't have to be done in pretty much all cases. And as I said, a urology referral is not needed if it's very mild. If a hypospadia is present, this is something just to keep in mind on. If a hypospadia is present, then neonatal circumcision is contraindicated. So you can't do circumcision if the child has a hypospadia. Surgical correction is mainly indicated if there's a risk of voiding dysfunction, if there's sexual dysfunction, or if there's some sort of developmental issues. But again, that's a conversation mainly with the family, or if the child's grown of age and they can make their own decisions, and they would be involved as well. And the aim of management is to essentially just restore normal function and to straighten the penis if they do have that ventral curvature. Moving on to inguinoscrotal swellings. So there's a huge list of differentials, but I've included sort of the main ones that would be relevant to you guys. So the first thing to decide is whether it's painful or non-painful. So painful swellings, the main one to consider would be a testicular torsion. So that would be your most sort of emergent one. But other things, an irreducible hernia is also quite severe. Torsion of the testicular appendage, an infection like epididymo-orchitis and testicular rupture. So a painful swelling is normally not benign. So it can be quite severe and tends to require pretty prompt treatment. Non-painful swellings can be quite benign, so something like a hydrocele or a varicocele. It can also be idiopathic scrotal edema. And the main thing that you would want to rule out is a testicular tumor if it's non-painful. So testicular torsion is is the main sort of diagnosis or differential that you want to rule out in the acute setting. So the main clinical features are severe and sudden onset groin pain. You can have swelling, although in the very short, very acute setting, there may not be. Nausea and vomiting is quite common, so around 80 to 90% of cases. And then your main examination findings would be a high riding testicle and an absent cremasteric reflex. So that, again, is very buzzwordy for testicular torsion. You can also get a thickened spermatic cord and some red-blue discoloration. Yeah, the diagnosis is mainly clinical. You don't need any imaging to diagnose it, particularly as this is a very time urgent thing. And an ultrasound tends not to be useful in the acute setting. So the management is essentially urgent surgical review. So when they come in, they need adequate analgesia. So it's probably something IV that need to be made nil by mouth until surgical review is done. Yeah, and this is a surgical emergency, and essentially the longer you wait, the more damage is being caused. So if it's not treated or reversed within 6 hours, then there can be irreversible damage, and that can have fertility issues in the future. The non-painful swellings, I just included this here. These are the RCH guidelines, so they're very good. I'm not going to go over most of these, but I think it would be great to know all this stuff. So the slides will be attached to this. So if you just want to have a look, or just pause the video and just have a look over the differences between this, that is quite important for your exams. Cool. So that's pretty much all for genitourinary stuff. Thanks very much for listening. If you've got any questions about anything, feel free to shoot me an email. My student email is there, or you can send me a Facebook message. But yeah, hopefully that was okay. I'd encourage you guys to look at the RCH guidelines. And then if you want a bit more information as well, we have some pretty cool summary sheets on our Google Drive. So feel free to have a look at those. But yeah, good luck.